Inside a human blood vessel, time leaves a physical signature. Over decades of constant pressure, the arterial wall loses its flexibility, accumulating microscopic damage that turns a pliable biological tube into a rigid pipe. This mechanical wear and tear drives atherosclerosis, the buildup of plaque within our arteries. The central clinical paradox of this disease is that the severity of the plaque increases sharply with age, even in patients who maintain perfect blood pressure, low cholesterol, and flawless lifestyle habits. Decades of longitudinal autopsy and imaging research have tracked this exact progression across human lifespans. This chart shows atherosclerosis prevalence by age group. By middle age, over half of adults already have some form of the disease. As patients enter their 60s, the acceleration is aggressive. In extreme old age, that line terminates at nearly everyone. Atherosclerosis operates as an intrinsic structural disease of human aging, compounding regardless of personal habits. This physical decline begins with vascular aging. This is the unavoidable loss of arterial elasticity and the slow accumulation of microscopic tissue damage over decades. This baseline mechanical wear and tear serves as the structural foundation, but the actual construction of the plaque requires an active biological engine. To understand how this works, we have to deconstruct the mechanics of arterial aging, starting down at the behavior of individual cells, and scaling up to the diagnostic tools clinicians use to measure the damage. To address a disease with a near 100% prevalence rate, we must look past systemic lifestyle factors and examine the biology of the aging cells themselves. Healthy endothelial cells maintain a continuous cycle of division, keeping the arterial wall smooth. Eventually, replication stops, causing cellular senescence. These older cells can no longer repair tissue damage. Instead of dying, they remain active, secreting inflammatory chemicals directly into the surrounding vascular tissue. In a younger environment, the immune system clears isolated damage. Here, the tissue is bathed in chemical pollution. These senescent zombie cells actively degrade the arterial wall, acting as the biological match igniting plaque formation. The body's immune system detects these chemical distress signals. Specialized immune cells called macrophages arrive to consume the debris and repair the tissue. Because the senescent cells never stop broadcasting their distress signals, the immune response is never resolved. This creates a state of chronic, low-level inflammation, known as inflammaging. In this inflamed artery cross-section, microscopic fissures open, allowing bloodstream lipids to accumulate inside the tissue. Due to immunosenescence, an age-related immune decline, older macrophages lack the capacity to clear these lipids. Exhausted, they become trapped, swelling the arterial wall and physically narrowing the channel. Through the combined forces of inflammaging and immunosenescence, a biological process that should act as a temporary healing response becomes a permanent growing plaque. Decades of cellular dysfunction eventually produce a macroscopic structure that clinicians observe in a hospital setting. To stabilize this chronic inflammation, the body resorts to a final defensive measure, calcification. It deposits minerals into the plaque, making it hard and brittle. This scan shows exactly what that hardened calcium looks like inside the body. The stark, bright white deposits are calcified plaques clinging to the coronary arteries. Clinicians quantify this specific buildup using the Agatston Coronary Artery Calcium Score, or CAC score. This score is a metric calculated from CT imaging that assigns a numerical value to the volume and density of calcium in the coronary arteries. Older adults frequently present with significantly higher CAC scores, a measurement scaling directly with the duration and intensity of their age-related plaque development. The CAC score provides a direct, measurable biological receipt documenting a patient's exact level of cellular senescence and inflammaging. That biological receipt eventually comes due. The progression of calcified plaque serves as the direct mechanical cause of myocardial infarctions, strokes, and peripheral artery disease. The primary danger here is rarely the slow, gradual blocking of the blood vessel. The immediate lethal threat lies in the structural instability of the brittle plaque itself. This diagram illustrates a plaque rupture. Under the mechanical stress of flowing blood, the brittle surface of the enlarged plaque cracks open, exposing the inflammatory lipid core. This immediately triggers rapid reactive clot formation cascading over the rupture site, completely blocking the channel. The silent process of aging transforms the artery from a flexible biological tube into a rigid, fragile structure, primed for a sudden cardiovascular event. Chronological aging is inevitable, but the progression of this arterial decay can be intercepted at any age. The baseline mechanical wear is countered by strict blood sugar management and adopting a whole food plant-based diet to drastically reduce circulating lipids. Regular, sustained exercise acts as a direct mechanical countermeasure, forcing the vessels to expand and actively improving long-term vascular elasticity. The scientific horizon offers a new level of intervention. Researchers are now developing targeted cellular medicines aimed at the root of the inflammatory engine. This field relies on Senotherapeutics. Senotherapeutics are experimental drugs specifically designed to locate, modify, or completely clear out the inflammatory senescent cells embedded in our tissues. By understanding the exact mechanics of arterial aging, from microscopic cellular senescence to systemic calcification, we transition atherosclerosis from a statistical inevitability into a quantifiable, manageable condition.